All right. If it's okay with you, we can go ahead and start. Thank you very much, Dr. Awais Aftab, for being here today. For those that don't know, Dr. Aftab is a psychiatrist and a clinical assistant professor at Case Western Reserve University in Cleveland, Ohio. His work focuses on conceptual and critical issues in psychiatry, has many published articles in top journals such as JAMA Psychiatry and American Journal of Psychiatry. He's written for very prominent publications, such as the New York Times and been quoted in LA Times. He has published books, including Conversations in Critical Psychiatry, published by Oxford University Press. He's a senior editor for the journal Philosophy, Psychiatry, and Psychology, and is very prominent online, writes on his Substack primarily with more than 10,000 subscribers from 120 countries. I'm one of those subscribers, and it's been a pleasure to really read his work and see his influence online. And thank you very much for being here today.
Uh, Thank you, Dr. Salim. A pleasure and an honor to speaking today. We'll be talking about changing views of psychiatric diagnosis and classification over the past 150 years or so. So, it's essentially covering a lot of the modern psychiatry era. And the talk is going to be a mix of history of psychiatry, philosophy of psychiatry, and some of the scientific aspects around psychiatric diagnosis and classification, especially kind of the merging dimensional ways of thinking about psychiatric classification, and we'll briefly touch on kind of the complex dynamic systems approaches and some of the other developments in psychological theory and behavioral neuroscience. So it'll be a mishmash of different things, but hopefully it provides you something thoughtful about how our ideas about psychopathology have been changing and evolving. Dr. Salim already kind of went over pertinent parts of the bio, no relevant kind of financial conflicts of interest, and this is the link to my psychiatry newsletter if anyone is interested. This is the book that Dr. Salim was mentioning, Conversations in Critical Psychiatry from Oxford University Press. It came out in late 2024, was published in December in the US and kind of earlier in September 2024 in the UK and Europe. And it's essentially an edited collection of interviews that were published under a series in Psychiatric Times of the same name, published from about 2019 to 2022, investigating various conceptual and controversial and kind of critical issues that surround psychiatry. And so, people are interested, we're welcome to check it out. So the aims of the talk appreciate the historical development of Kraepelinian and neo-Kraepelinian psychiatric classifications, and I think a lot of people would be aware of what Kraepelinian and neo-Kraepelinian are, but if you're not, you'll find out soon. Examine how questions of classification have intersected with questions about the nature of mental illness, recognize contemporary developments in dimensional approaches to psychopathology, and discuss considerations around theory crisis and psychology and behavioral neuroscience. And our story starts in the mid 19th century with the German psychiatrist Wilhelm Geisinger, very influential psychiatrist of his era, one of the founders of modern psychiatry as we know it. We often hear the statement that mental illnesses are brain disorders or mental illnesses are brain diseases, and people sometimes use it to mean various different things. There's a rich philosophical debate around this whole idea of in what sense mental disorders can be brain disorders. Some people taking a general physicalist view that mind, whatever it is somehow grounded in the brain. Therefore, any kind of disturbances in the mind could, by inference, be considered disturbances of the brain as well. Greisinger clearly articulated this idea that mental illnesses are brain diseases. So this is one of the kind of early, clear, modern expressions of this idea. But he meant it literally. He meant that mental illnesses were similar to neurological diseases, that there were neurological dysfunctions, brain dysfunctions in the same way as existed in neurological diseases, and that we could study them and discover them. So under the influence of Geisinger, a whole generation of European psychiatrists devoted themselves to neuroanatomy and neuropathology of the brain. And at that time, there were very limited treatments. Psychiatric asylums were predominantly for containment from society. So many psychiatrists, called alienists at the time in Europe, would wait for these patients to die, and then they would examine postmortem, examine their brains, try to find evidence of pathological anatomical abnormalities. By the time Emil Kraepelin, who's one of the founders of modern psychiatric classification, by the time Kraepelin emerges on the scene as a young psychiatrist in 1880s, the failure of that paradigm, that research agenda, has become evident. So this is Kraepelin writing in 1886. Geisinger insisted that hopes for an expansion of psychiatric knowledge rested on the study of neurological diseases. Nevertheless, to date, it cannot be said that our understanding of mental disorders has been significantly advanced by the results of pathoanatomic studies of the brain. Um, he's taking stock of the fact that for the last 30 years or so, psychiatrists were studying the neuroanatomy in the hope that they will find abnormalities similar to neurological diseases, but it didn't lead them very far. So what happened? And this, by the way, is a sentiment that kind of advances in neuroscience have not translated into significantly increased understanding of psychopathology. Just kind of you see one thought leader and another repeatedly say the same thing every 20, 30 year, and we still hear similar sentiments these days as well. So, Grappling, by the time he arrived, he was working on an intellectual landscape that had been shaped by two important predecessors, Carl Kahlbaum and Ewald Hacker, both influential psychiatrists of their era. Kahlbaum, as many know, was one of the first to give a clear description of the catatonia syndrome, and the way he described the catatonia syndrome still has relevance to our contemporary understanding of it. Kahlbaum and Hecker similarly were dissatisfied with the outcomes of the Greisinger's research program of neuroanatomy and neuropathology. And they felt that the main reason that research program had failed was because the psychiatric terms and the diagnostic categories that were being used at the time, they were just too heterogeneous and diagnostically not specific, and that reliance on those categories, and at that time they had these general terms like mania, melancholia, insanity, dementia, etc. That reliance on them had furthered confusion and led to failure of neuropathological research. That etiological research would not yield results until it was guided by proto-disease entities, determined not only by symptoms but also by considerations of longitudinal course of illness, that is kind of the natural history of the condition. And the paradigmatic example they had of the fruitfulness of such an approach was the condition at that time called general paresis of the insane, also sometimes called general paralysis of the insane, which we now recognize as being advanced neurosyphilis or tertiary syphilis. Kahlbaum and Hecker did not know what the cause of general paresis of the insane was. The spirochete was discovered a few decades later in the early 20th century. So even though they did not know that this was caused by a bacterium, the syndrome itself had been well described, its different phases and stages mapped out, and it was recognized that this distinct disease entity that is different from whatever else is going on in the psychiatric realm. So by paying attention to distinctive symptoms and by paying attention to natural history of the condition, they were able to identify a proto-disease entity that then yielded etiological results. And they felt that if we did a similar thing with other mental disorders, we would make more progress. And so instead of just kind of starting with speculations or conjectures about causes, we should give more importance to natural history descriptions and start from there. Now, I want to share some quotes from Kahlbaum and Hecker just to kind of illustrate how modern their thinking sounds, in certain ways, and how the concerns that they are bringing, still resonate a great deal with us. So this is Colbum writing in 1863. The various forms in which mental illness has been known since antiquity and is still known today cannot be considered as different species in their own right, but only as symptom clusters which can appear in the course of different disorders. And Hecker writes in 1871, the commonly accepted names for psychiatric illnesses, that is, melancholia, mania, insanity, confusion, and dementia, are completely unsuitable and insufficient because these names do not designate true disease forms but temporary conditions. The subtle anatomy and physiology of the brain are still in a dismal state, and the pathological anatomy of the psychosis up to now has offered us extremely few hard facts. No wonder we find in mania at times this and at that times that change in the brain. Would it be any different if we were to trace the anatomopathological substrate of abdominal pain? And kind of as you can tell, you could find these statements in a journal from 10 years ago, and you would not be surprised to find these statements. And to show that, I'll show you two quotes from Thomas Insel, who was former director of National Institute of Mental Health and a big force behind the development of the research domain criteria, RDoC. So Thomas Insel writes in 2012, in mental health, we are stymied by our language. The most obvious linguistic problem can be found in our current diagnostic terms, what my predecessor Steve Hyman has called fictive categories. Terms like depression or schizophrenia or autism have achieved a reality that far outstrips their scientific value. Each refers to a cluster of symptoms similar to fever or headache, but beyond symptoms that cluster together, there should be no presumption that these are singular disorders, each with a single cause and common treatment. Um, okay. And all right, I'm just making sure everyone can hear me. All right.
Yep.
Okay. All right. Good.
Always good. Thank you.
All right. So, and then Thomas Insel, then he again kind of writes something similar in 2013. The DSM diagnoses are based on a consensus about clusters of clinical symptoms. In rest of medicine, this would be equivalent to creating diagnostic systems based on the nature of chest pain or quality of fever. Imagine deciding that EKGs were not useful because many patients with chest pain did not have EKG changes. That is what we have been doing for decades when we reject a biomarker because it does not detect a DSM category. So you can see, strong kind of resonance between the kind of concerns that Kalbam and Hecker are kind of raising, and which influence the development of Kraplin's classification, and the kind of concerns we have in the contemporary DSM ICD landscape, which is also based on symptom based categories. However, there is a crucial difference in the state of affairs in terms of our scientific understanding. The difference between 1860s and 2020s is that while Kolbam, Hecker, and Kreplin had good reasons to assume the existence of disease entities in psychopathology, disease entities similar to neurosyphilis, that were hidden behind confusing and heterogeneous symptom clusters, we no longer have good reasons to hold on to that assumption. Because the bulk of scientific evidence and kind of research that we have point toward a more spectrum and continuum-like picture, a dimensional picture rather than categorical one in which there are natural discontinuities in the landscape of psychopathology. A good example of that comes from this meta-analysis that was published in Psychological Medicine in 2020. This was by Nick Haslam and colleagues, and this was a meta-analysis of taxometric research. So taxometric is a branch of biostatistics and medical statistics that examines distribution of symptoms to try to identify whether this points towards natural discontinuities, in a statistical sense, underneath that distribution or no. So Haslam and colleagues, they comprehensively examined all available taxometric research, over the last several decades, and the overall overwhelming kind of conclusion was that these point towards a dimensional interpretation rather than a categorical one or a taxonic one. So findings supporting dimensional models outnumbered those supporting taxonic 5 to 1. And in fact, the more rigorous the studies were, and the more they use methods that are currently seen as superior, the more the research supported a dimensional interpretation. And so the meta-analytic findings kind of supported the idea that the great majority of psychological differences between people are latently continuous, and that psychopathology is no exception. And that in the same meta-analysis, when they compared kind of findings from mental illness categories to other aspects of psychology like personality functioning, the degree of dimensionality was pretty similar. So at this point, we can no longer hold on to the assumption, or we can't take it for granted that there are undiagnosed disease entities hiding behind these large symptom clusters, by and large, and that we will identify them. Now let's jump back into the kind of the historical arc that we are tracing. So Kraepelin comes in this landscape that is shaped by Kahlbaum and Hecker. Kahlbaum and Hecker emphasize, let's pay importance to natural history. So Kraepelin kept meticulous records of patients, very detailed observations over years and decades, and based on those meticulous clinical observations about symptoms, natural history, longitudinal course of illness, prognosis, he separates out, he creates his own psychiatric classification. And just as DSM has, different editions and huge influential, and every new edition, is kind of received with some degree of enthusiasm and anticipation. There was a similar kind of thing with Kraplin's psychiatry textbook as well, with the first edition coming out in 1883 and the ninth edition coming out in 1927, around the shortly before his death. And the landmark edition is often considered the sixth one. In that he presents the distinction between dementia praecox and manic depressive insanity. Dementia praecox is a category that is a precursor category to our contemporary notion of schizophrenia. And the main distinguishing feature between dementia praecox and manic depressive insanity for Kraepelin was the longitudinal course of illness. That in dementia praecox, the problems start relatively early in life, kind of adolescent, teenage years, or young adulthood, and then there's a steady, progressive, and declining course with subsequent kind of dissolution of personality and cognitive functioning. So a steady decline resulting in a dementia-like state, versus in manic depressive insanity is a more recurrent course with relative preservation of personality and cognition, especially in between episodes, and not the same kind of steady pace of cognitive decline. So the distinction, so the ideas about natural history, course of illness played a strong role in coming up with this differentiation. Now, I think a layperson understanding of Kraepelin is often that Kraepelin was very biologically focused and didn't really take psychology very seriously. But the reality, in fact, is that Kraepelin saw psychology as a very important discipline. He thought it was a natural science in the same way as kind of biology, chemistry, and others are. And Kraepelin, in fact, studied with Wilhelm Wundt, who is one of the founders of modern psychology. Kraepelin believed that psychiatry, like other sciences, deals with natural phenomena, that there exist natural kinds or natural disease entities, and the task of psychiatric classification is to discover them, and that he himself sought to identify these disease entities through an iterative process of careful clinical observation and follow up. So the idea of disease entity and kind of, that there are natural kinds of, categorically distinct entities that exist in psychopathology was important to Kaplan, and it was a guiding force. And a similar kind of related idea that inspired Kaplan was the idea of convergence of validators, that there are different ways of studying illnesses and diseases in medicine. We can look at pathological anatomy. We can look at etiological risk factors. We can look at clinical symptomatology, including course of illness. And that Kraepelin felt that if we had comprehensive knowledge, then they would all point in the same direction when it comes to natural disease entities. So in the sixth edition of his psychiatric textbook in 1899, he writes, judging from our experience in internal medicine, it is a fair assumption that similar disease processes will produce identical symptom pictures, identical pathological anatomy, and an identical etiology. If therefore we possessed a comprehensive knowledge, all of these classifications would exactly coincide. And this kind of provides the basis for our more modern idea of convergence of validators, which I will talk about when we talk about neo-Kraepelinian movement, which is that if we look at different ways of validating an illness, we look at family history, genetic associations, neuroimaging associations, course of illness, response to treatment, and when we're dealing with disease entities, they would all converge to kind of point towards that categorical thing. There would be some degree of alignment between those different validators in the case of these entities, and so it kind of goes all the way back to Kraepelin, Kraepelin's notion. Now, just as we, in our day, we, kind of DSM, meets with a variety of kind of conceptual reactions, the reactions to Kraepelin's work were pretty diverse as well, and those reactions are still pretty relevant and have something to teach us about these discussions. So, Alfred Hoche, for example, who was a contemporary physician of Kraepelin, he pointed out that that Kraepelin is just assuming that the anatomy symptom relationship that exists in general medicine is going to be pretty similar to the anatomy symptom relationship that exists in psychiatry. But he said that's just an assumption. We don't have good reason to make that assumption. In fact, it's quite possible that the anatomy symptom relationship may be very different in the case of mental health problems than it is in general medicine. In fact, kind of as we'll touch on near the end with some of behavioral neurology stuff, even kind of neuroscience is re-examining, these debates, and the relationship between brain and behavior is very different from, let's say, kind of, like the functioning of the heart or the functioning of the kidneys. Then Adolf Meyer, who was kind of arguably the most influential American psychiatrist of the early 20th century, Meyer thought that a focus on illness scores cannot adequately separate disease entities because of considerable influence of social and environmental factors. So Meyer said that you can't say that, oh, this thing has poor prognosis and this thing has good prognosis, so there must be separate disease entities, biological disease entities, when because so much of prognosis is shaped by social and environmental factors, and it's a confounding factor there. And so Mark doubted that that you could distinguish disease entities based on prognosis in this manner, the way Kraepelin was doing with dementia praecox and manic depressive insanity. And Meyer went on to develop his own not biopsychosocial, kind of a psychobiological approach, which was a precursor to biopsychosocial. And he conceptualized mental illnesses as being reactions to life circumstances. And this heavily influenced the development of DSM-1, which is why DSM-1 uses the language of reactions, because that was the Meyerian language at that time. And then Karl Jaspers, who was the most kind of philosophical of Kraepelin's critics, he also thought that the idea of natural disease entities was problematic in when it came to psychopathology and mental health problems. And he thought that instead of natural disease entities, a better way to think about psychiatric diagnostic categories might be through what he called ideal types. And this is what we would today call prototypes. That is, we have a certain exemplar of a certain category. We have an illustrative example of what that category looks like, but variation within that category is possible, and different individual cases can approximate that prototype to different degrees. So it gives a kind of illustrated ideal example, but it recognized that there is variation and fuzziness, and there are going to be atypical scenarios and kind of situations. So he advocated for a more prototypical understanding of psychiatric categories, which also kind of, from contemporary perspective, meshes in with a pragmatic and practical kinds of view of mental health problems. And then Jaspers also emphasized the need for explanatory pluralism, that we have different modes of thinking about mental health problems. There's a more mechanistic cause and effect, causal explanation of mode of thinking. But then we also have a more psychological, phenomenological, empathetic way of understanding in the psychological realm of the sort that psychodynamic thinking exemplifies. And he emphasized that we cannot look at mental health problems from just one mode of thinking, that we require causal explanations as well as psychological understanding in equal measure. All right. So we're gonna jump a little bit and gonna jump to mid 20th century, an era that was characterized by conflicting attitudes towards psychiatric classification. Psychiatrist Erwin Stengel was commissioned by the World Health Organization to review existing classifications and produce a detailed report. And that report is really kind of really interesting to read. It was published in 1959, and one passage from that report in particular caught my eye, and I think is reveals something quite fascinating. So Stengel writes in 1959. Recently, the attitude of many psychiatrists towards the conventional type of classification has become one of ambivalence, if not of cynicism. This attitude derives partly from a low estimation of diagnosis. Classifications based on the Kraepelinian system have continued to be used in some form or other all over the world. Many psychiatrists have done so under protest and expressing their disbelief in the working hypothesis underlying that system. So he's Kraepelinian classifications were still quite popular in the 1950s and 1940s, and psychiatrists were using them, but a lot of them did not believe in the kind of the assumptions, the foundational assumptions that Kraepelin had utilized. And kind of mid 20th century is also when we see the rise of psychoanalysis as well, especially in North America. And psychoanalytic folks just were not that particularly interested in the issue of diagnosis and classification. They were much more focused on individual case studies and developing more, developing richer ways of psychological formulation. So that also contributed to neglect of classification and this development of ambivalence. And I'm going to come back to Stengel's quote later in my talk, because I feel we are similar in a similar kind of era of nosological ambivalence again, due to all the limitations of DSM and ICD. Another thing that was happening in the mid 20th century was a crisis of reliability. A wave of research studies had demonstrated a problematically poor inter-rater reliability of psychiatric diagnosis, that different clinicians could not agree on what the diagnosis was for a particular individual, and this highlighted the need to place psychiatric nosology on a more stable footing. There was a famous set of studies known as the US-UK Diagnostic Project, which compared diagnostic practices in the East Coast of the US and the UK. And in one study in particular, they showed psychiatrists on US East Coast and the British psychiatrists videos of patients being interviewed. And then the psychiatrists had to rate what symptoms and signs they thought were present and to give a diagnosis. And it highlighted alarming discrepancies. The patients that American psychiatrists would call schizophrenia, the British psychiatrists were calling manic depressive insanity, or they were calling personality disorders. So it highlighted that even at the international level, there was a big discrepancy between diagnostic practices, and that there was a tremendous need to bring these into alignment. So in this context of nosological ambivalence and crisis of reliability, we see the emergence of a group of psychiatrists that we now call neo-Kraepelinians. And the story kind of goes that in the 1960s, every psychiatry department chair in the U.S. was a psychoanalyst, except the department chair at Washington University in St. Louis. And so that university, Washington University, became the hub of a medically oriented approach towards psychiatry. And this was led by a group of young and dynamic psychiatrists at the time. There were Samuel Gouset, Eli Robbins, George Winnaker, and they were dissatisfied with the prevailing psychodynamic way of thinking, and they wanted to bring back the kind of ideas that had animated Kreplin and other figures around them, and taking inspiration from the Kreplinian approach, they in a landmark paper in 1972 they presented diagnostic criteria for use in psychiatric research, which was I think nearly 2 dozen conditions that had relatively good empirical support from literature. They presented specific descriptive and operationalized criteria for how to talk about and recognize those conditions. And in a separate paper, Sam Guzay and Eli Robbins had also presented their criteria for how to think about validity of psychiatric syndromes, and drawing on the idea of convergence of validators from Kraplin's, kind of Robbins and Guzay emphasized that different validators like family history and neuroimaging associations and course of illness, etc., could be used to validate psychiatric syndrome. So the neo-Kraplinian approach was emphasizing that psychiatry should operate within the quote unquote the medical model, and by this the neo-Kraplinians were trying to distance themselves from the psychoanalytic camp, because they didn't think that what was going on in psychoanalysis counted as medicine. That was their perception, and so they wanted to bring psychiatry back into the way of thinking that better characterized general medicine for them. Similar to Kraplin, the neo-Kraplinians were of the view that there are natural disease entities in psychiatry. There are, brain diseases. There are neuropathological entities to be discovered. There can be no scientific psychiatry without a serious systematic effort to develop a valid classification of psychopathology. Such a serious systematic effort requires operationalized diagnostic criteria, that is, a precise list of symptoms and clinical features that can be used to make a diagnosis. That research into biological aspects of mental illness is crucial for the identification of disease entities, because these are biological dysfunctions, so that makes sense. And then validators such as clinical presentation, neurobiological findings, longitudinal course of illness, family history, genetics will converge when we identify psychiatric disease entities. So again, kind of like validators converging is an important part of this worldview from them. And they were not shy about any of this. In fact, they were not shy about the emphasis on biological aspects and them being biological diseases. This is, for example, a title of a paper from Sam Guzay from 1989, rhetorically titled "Biological Psychiatry: Is There Any Other Kind?" So so they were pretty open about what their assumptions and what they considered to be the right or the desirable way of studying psychopathology. Now, the neo-Kraplinian approach had a huge influence on the development of DSM-3, which was published in 1980. And these are not explicitly acknowledged in the manual in many ways, but they are kind of operating, they're hidden and kind of operating behind the scene. And recognizing the influence of neo-Kraplinian assumption is kind of the only way of making sense of the fact that DSM-3 was seen as a victory of the medical model and biological psychiatry, even though, technically speaking, it's a descriptive manual and it claims to be atheoretical with regards to etiology. So the only way a descriptive atheoretical manual can be seen as a victory of medical model and biological psychiatry is if it is taking the neo-Kraplinian assumptions for granted. Now, to kind of make some of this historical discussion kind of more complicated, Robert Spitzer, who was the chairman task force of DSM-3 and kind of the force behind that, he himself was not a neo-Kreplanian. He was very inspired by, I think he admired the work they did, and the operationalized approach that they developed for research, purposes. He took that and he applied it clinically to all psychiatric disorders. And in fact, there was a paper in Schizophrenia Bulletin in kind of 1982 in which Spitzer openly says that he's not a neo-Kreplanian. He distances himself from that, and he says that because he's agnostic about whether there are categorical these entities, and he's also not that committed to the focus on biological research at the expense of psychosocial research. But it is the case that many neo-Kreplanians were prominent members of the DSM-3 task force, and the influence of neo-Kreplanian thinking on DSM-3 is a matter of historical record. And those assumptions guided psychiatric research over the next 3 decades. In 1980, 1990s, early 2000s, the tendency was to treat DSM conditions as if they were categorically distinct entities, and they would, we would try to find the genes for bipolar, or genes for depression, or the brain regions responsible for them, etc. And by the time DSM-5 is being developed, or kind of the revision process is being undertaken, the failure of that research program has become quite evident. So in the white paper for DSM-5, which was published in 2002, at that time DSM still had the Roman numeral at the time. The kind of Kufer and others, they write. In more than 30 years since the introduction of the Feiner criteria by Robbins and Guzet, which eventually led to DSM-3, the goal of validating these syndromes and discovering common etiologies has remained elusive. Despite many proposed candidates, not one laboratory marker has been found to be specific in identifying any of the DSM-defined syndromes. Epidemiologic and clinical studies have shown extremely high rates of comorbidities among the disorders, undermining the hypothesis that syndromes represent distinct etiologies. Furthermore, epidemiologic studies have shown a high degree of short-term diagnostic instability for many disorders. With regard to treatment, lack of treatment specificity is the rule rather than the exception. So everything we would expect if psychiatric conditions were categorically distinct entities, we were not seeing in psychiatric research by early 2000. That it was pretty clear that this was happening, and this led to a state of affairs in which more and more psychiatrists, especially clinical psychiatrists, became skeptical of the value of DSM as a diagnostic enterprise. So for example, Sandra Steingart, who's a kind of well-known critical psychiatrist, she writes at one point in 2014 about as exemplifying this loss of faith in the neo-Kreplanian worldview. She says, "I'm not denying that humans experience psychosis or have disabling bouts of dysphoria or extremes of increased energy and mood elevation. I'm just saying that our current constructs map sloppily onto the heterogeneity of human experience. Also, by looking at how we now prescribe our drugs, extremely non-specific to our syndromes, and even more importantly, by examining approaches that seem to be helpful but ignore our diagnostic classification, like many psychosocial interventions do, I'm growing increasingly uncertain that it really matters how we define and classify these things." And there's a big chunk of clinical clinicians in the mental health area who feel this way, who don't kind of who are not convinced that it really matters what precise DSM diagnosis you give something. And that's why we see many psychiatrists who, for example, who give unspecified everything, unspecified mood disorder, unspecified psychosis, etc., because they don't think it really matters. And in some ways this is kind of a playback of the kind of ambivalence that Stengel was noting in the late 1950s. This is the passage again from his report. "Recently, the attitude of many psychiatrists towards the conventional type of classification has become one of ambivalence, if not of cynicism. This attitude derives partly from a low estimation of diagnosis. Classifications based on the Kraepelin system, and in our case, DSM and ICD, have continued to be used in some form of other all over the world, many psychiatrists have done so under protest and expressing their disbelief in the working hypothesis underlying the system. And the working hypothesis in our case are the neo-Kraepelinian hypothesis that guided the rise and influence of the manual. And in some ways, this was not unpredictable. Robert Kendall, a very distinguished British psychiatrist, he wrote in 1982, kind of 2 years after DSM-3's publication, those who are out of sympathy with the aims and philosophy of the Neo-Kraepelinian school can console themselves with the thought that its present dominance will not last forever, or even for long, if it commits itself to a crude belief in discrete disease entities and ignores the effects of social and psychological influences. And in some ways, that's kind of what happened, and Kendall's prediction was not heeded. Now, I want to clarify that the scientific picture that that is emerging and that we are currently in possession of, it does show that there are mechanisms and processes involved in psychopathology. So it's not the case that this is some fabricated thing that we are dealing with, but the key problem is that these mechanisms do not converge onto quote unquote disease entities. So, for example, Bruce Cohen and Dost Unger, both distinguished psychiatrists. Dost Unger is the editor-in-chief of JAMA Psychiatry, as some people might know. So they write in a paper in Molecular Psychiatry in 2023. Of particular note, unlike diseases that are heterogeneous in expression but share a single cause, or diseases that are heterogeneous in cause but share a single expression, psychiatric disorders are heterogeneous in all ways and at all levels studied in cause, mechanism, and expression of illness. And that's one thing I think, if you remember one takeaway from this talk, is this is the kind of complexity we are dealing with in mental illness, is heterogeneous in all ways and at all levels studied in cause, mechanism, and expression of illness. Things don't just seem to come together at a one level the way we see in many neurological conditions, or we see kind of the classic diseases in infectious medicine, for example. The same kind of point is made by the psychiatrist Kent Kendler in a 2012 paper in which he compares the kind of explanations around cystic fibrosis and alcohol dependence or alcohol use disorder. And he kind of shows that in the case of cystic fibrosis, there's an essence there. There's a central cause onto which everything converges, and that is the CFTR mutations. And that gives us a lot of the things we desire from a causal explanation. Gives us strength, causal role, generalizability, specificity, manipulability, etc., etc. Versus we look at something like alcohol dependence, and the kind of the quote unquote validators are all over the place. There's the latent genetic risk, ALDH variants, GABA receptor variants, childhood sexual abuse, frontal lobe dysfunction, impulsivity, peer deviance, social norm expectations, taxation. So it's unlike cystic fibrosis, which has an essence and things onto which things converge. It's a mishmash of heterogeneous kind of mechanisms and processes intersecting in complex and complicated ways. Another kind of aspect of this is that the psychiatric categories that we are dealing with, the reasons due to which we're calling them disorders, is very folk psychological in nature. Our judgments of psychopathology are commonsensical, intuitive, characterized by what we can call folk psychological thinking. That is, when does or why do we consider these problems as mental illnesses or as psychopathological? Because the behaviors and experiences are unexpected and unfamiliar. They're not easily intelligible. They are disproportionate in reaction or excessive in some manner. They break the rules of social conduct. They violate norms of shared rationality. They're not subject to ordinary expectations of intentionality and volition. And of course they're typically distressing or disabling. And if you go through DSM and ICD criteria, you see how this playing out, how we define symptoms using these folk psychological commonsensical kind of terms. And the question is that why should our folk psychological intuitions map onto neuroanatomy or neurophysiology in any meaningful way? Why should distinctions in folk psychology correspond to distinctions in functioning of the brain? And again, I mean, if you put it in that terms, you can see that we cannot just take it for granted that these distinctions are going to have natural correlates, in the functioning of the brain. So, in light of all this, we are confronting a post-Kraplanian landscape of psychopathology. That instead of disease entities, we have to tackle a web of mechanisms and processes of maddening heterogeneity. And that, as far as we can tell, and this is kind of, based on taxometric research and other things, that statistical distribution of psychiatric symptoms in a population, it is dimensional in nature. It does not have natural discontinuities. And also it is hierarchical. It can be described at varying levels of statistical specificity. And I'll give you an example of that using high top a few slides later. So it seems dimensional, it seems describable as statistically hierarchical. And then if you look at what's happening within person changes in these psychopathological states seem to be describable as dynamic states and phase transitions in a complex dynamic system, such that a system is switching from one phase to another, that can be described using tools of complex systems. From a clinical perspective, the problems can be treated as idiographic as well as nomothetic. Idiographic, that there's a particular individual trajectory of those things. There are distinctive things about one individual having these problems, and the particular manner in which they involve in one person, exemplified by, for example, a psychological formulation or a psychodynamic formulation of an individual. But there are also nomothetic. There are general patterns that we can talk about and we can identify, and we can classify. And the value of idiographic versus nomothetic kind of changes from context to context and person to person, but you can look at them both ways. And then there's considerable social influence, and there's a feedback loop between classification and behavior. If when a chemist classifies elements, or when a biologist classifies species, the behavior of elements and species does not change. But when you classify humans with psychiatric disorders and psychiatric labels, they're aware of being diagnosed, and their behavior subsequently can be different. A person diagnosed, for example, with autism spectrum is now going to have a different view of how to understand their self, and their behavior is going to be different. So, unlike the natural world, classifications interact with human behavior, and philosophers call this looping effect, with the philosopher Ian Hacking being the one who described it quite well. And then, unlike neurological disorders, where we can recognize a neurological function going wrong at the neurological level, there are brain mechanisms involved in mental illnesses for sure, but those brain mechanisms cannot be characterized as dysfunctional at the brain level. They can be characterized as dysfunction only in an indirect sense, that they are associated with maladaptive behaviors. So we are characterizing the behaviors and experiences as dysfunctional, and then we are saying by indirect inference that the mechanisms involved are also dysfunctional. But if we were to look at mechanisms themselves in isolation without reference to the behaviors, we wouldn't have a reason to say that there's anything dysfunctional about them. They might be different, but saying that they are dysfunctional would be kind of different story. And this last point in particular, there has been pretty extensive philosophical discussion around it, thanks to Annalee Jefferson, who is a British philosopher. Her book came out a few years ago, Our Mental Disorders, Brain Disorders, and I engaged with that, and this is my commentary on her book in philosophical psychology, which kind of elaborates on this point and discusses this. And if you're interested in the philosophical thinking around that issue of when can we characterize brain function mechanisms involved as being functional versus dysfunctional, you can check out this literature. So we're kind of, we're looking at a pluralistic future of psychiatric nosology as a result of all of this. There's a need for parallel development and simultaneous use of multiple classification systems. We need to abandon the idea of one classification to rule them all, or insist on naive winner takes all paradigm shifts that one method wins and gets all the funding and prestige and resources, and the kind of like, others get nothing else. So we are seeing a resurgence of clinical prototypes. Kind of, like many clinicians now think not in operationalized criteria, but rather in terms of prototypes. They have different illustrative examples of what bipolar disorder looks like, schizophrenia looks like, autism looks like, that allow for fuzziness, that allow for kind of atypical cases, and they try to match patient presentations with prototypes. So prototypical thinking has made a comeback, similar to Jasper's ideal types. We have dimensional and hierarchical approaches, exemplified currently really well by Hightop, hierarchical taxonomy of psychopathology. We have neurobiological and neuropsychological approaches like research domain criteria, phenomenological approaches. There's a group in Scandinavian country that is doing some excellent work. Ideographic psychodynamic formulations like psychodynamic diagnostic manual, and other forms of psychiatric formulation like the perspectives approach from McHugh and Slaveney are good examples of this kind of pluralistic landscape of diagnostic thinking. This figure illustrates the high top project, hierarchical taxonomy of psychopathology. This figure itself is a bit outdated, but I use this one because it's easier to read, and it's easier to kind of read the text in the boxes. The basic idea is that kind of like symptoms and symptom variations can be arranged at different levels of specificity. At the bottom, you have kind of individual symptoms and signs and clinical features and maladaptive traits. And then if you look at patterns of statistical covariation and co-occurrence, so you have, if you have, let's say, large data sets of psychiatric symptoms, and you do factor analysis on them to see what kind of statistical patterns emerge, what you see is that you get different clusters of psychiatric symptoms, so what we call subfactors. So you have the fear subfactor, distress subfactor, kind of sexual problem subfactor, substance abuse, antisocial behaviors, and each one explains a shared covariance of symptoms associated with these different kind of conditions. So, for example, in this statistical clustering, depression, anxiety, PTSD don't show up as separate latent factors because they're really heterogeneous syndromes. But kind of like but they're all of these conditions have shared statistical variance that is expressed by this latent factor of distress. And then these conditions, for example, have a statistical shared variance in the factor of fear. And then at a higher level, there is shared variance among these different symptom patterns that is shared by the internalizing spectra, for example. And there are 6 spectra, and spectral level forms the backbone of the high top project. So there's the internalizing spectra, externalizing, which is divided into disinhibited, antagonistic. There's detachment, thought disorder, somatoform. And then, interestingly, at a still higher level, there are portions of shared experience that are captured by a general factor of psychopathology, also called the P factor. So just as we have the G factor in intelligence, there are many different aspects of intelligence, different ways in which it can manifest. But statistically speaking, it can be captured. A big chunk of that can be captured by the G factor, reflected by the IQ. In a similar kind of way, we have a wide range of mental health problems, but statistically speaking, you can talk about one latent factor called the P factor that explains a big chunk of the variance along this issue. And there's some very interesting discussion in the scientific literature on how to understand and interpret the P factor, whether it represents something in reality in terms of like a risk factor shared by all mental illness, or some kind of protective factor, or whether it is just a statistical construct, a statistical way of looking at things. And the debate is still ongoing. But the key thing is that in the high top, we have this hierarchy, and every person's symptom profile can be rated along any of these dimensions. So, for example, if we focus on spectra, each person's symptoms can be rated whether they're high on internalizing, high on externalizing, high on thought disorder, and that generates unique profiles for each person. So this is a high top profile for a fictional case. And on y-axis, we have normalized t-scores with a mean of 50. So 50 represents the average, and each 10 kind of standard deviation of 10 kind of like kind of is used as a threshold, as a marker for severity. So one standard deviation away, kind of mild problems start. Then two standard deviations away, kind of like moderate. Mild to moderate is kind of one to two standard deviations, and more than two standard deviations, you get start having severe problems. And so, using rating scales, you can develop a profile. So this person, for example, has kind of severe problems in internalizing and kind of somewhat mild problems in antagonistic externalizing, while the other is relatively unremarkable. And then in terms of, if you focus on the symptoms and traits, you can see which ones are elevated. So kind of dysphoria is pretty elevated for this person. Insomnia is elevated. Appetite loss. There's kind of panic, social anxiety. So you get this, instead of a categorical description of whether a person meets a categorical diagnosis, yes or no. You get this more kind of multi-dimensional symptom profile, and a person can have many different combinations or ratings of what this might look like. Let's have another example, kind of like, in the high top approach to psychotic disorders, we have two main dimensions. We have the thought disorder or psychoticism dimension, and we have the detachment dimension. And the psychoticism kind of covers the more positive symptoms like things, but they are on a continuum with ordinary population. So things like, for example, fantasy proneness, unusual experiences, peculiarity, they're on a continuum with more severe things like delusions, hallucinations, thought disorganization. And then the detachment spectrum kind of captures the more negative symptoms, again existing on a continuum, with one end being in the normal population, and clinical population being the other end. And then we have two auxiliary domains. We have the cognitive domain and functional impairment domain. And so any particular person with a psychotic disorder can have different values along these four dimensions. One person may be high on psychoticism but low on detachment, maybe low on cognition but kind of high on functional impairment. The classic profile for schizophrenia, the prototype of schizophrenia, is someone with high psychoticism, high detachment, high cognitive dysfunction, and high functional impairment. But that's just one possible, value, kind of pattern that this, a person can have, which is why we see in the real world, we see fuzziness. Like one person can be low on psychoticism but high on detachment, and different people can have different cognitive status, different people can have different functional impairment status. So we get all possible combinations of values along these four axes, only some of which satisfy our classic idea of what schizophrenia looks like, kind of like, which is why in reality we have so much, diversity and fuzziness of psychotic problems. And then one area where dimensional thinking has become the most commonly accepted and somewhat mainstream are the personality disorders. So in DSM-5, in the alternative model of personality disorder, which is in the section 3 of DSM, and then ICD-11 has moved to a completely dimensional models. Both of them have 5 dimensions of psychopathological personality, and then any person with a personality problems can be rated along these 5 dimensions. So in DSM-5, for example, negative affectivity is the person kind of low, moderate, severe on negative affectivity, on detachment, on antagonism, on disinhibition, on psychoticism. In a similar kind of way, you can rate any person's personality problems along these 5 dimensions. Now, in psychoticism, in ICD-11 belongs in a different chapter. It's pooled in with schizophrenia spectrum. So they have an ankastia, which refers to obsessionality, as a replacement for that. But in ICD-11, you don't have the categories anymore. There is no narcissistic personality disorder, no schizoid personality disorder, kind of like no cluster C, etc. But rather you have a profile of of symptom ratings along these five dimensions. The only exception ICD-11 made was with borderline personality disorder, where due to strong insistence of clinicians, they retained a borderline pattern specifier, not a subtype, but a specifier. But they emphasize that the substance of the classification remains dimensional along these five axes. So again, a kind of like a switch from a categorical way of thinking to a dimensional way of thinking, which generates distinctive profiles for each person. A similar kind of shift has been happening in brain circuit research as well. So, for example, Leanne Williams at Stanford, her work has been kind of really foundational and groundbreaking in this area. And she presented in 2016 her preliminary ideas about how we may approach the study of mood and anxiety disorders from a brain circuit perspective. And based on a review of literature, she identified these basic brain circuits that had been that play a prominent role in regulation of mood and behavior. So there's a default mode circuit, there's salience network, there's negative affect circuit, positive affect, there's attention and cognitive control. And for each of these circuits, we can have either hyperactivation of those circuits or we can have hypoactivation of those circuits. And then with regards to the connectivity between the nodes of these circuits, we can have hyperconnectivity or we can have hypoconnectivity. So we can have different combinations of hypoactivation and hypoconnectivity along these six kind of basic circuits, which generate different profiles that we associate with different clinical features. So with rumination, we kind of see this pattern of kind of like default mode kind of circuit activation. There's anxious avoidance, negative bias, threat dysregulation, cognitive dyscontrol, inattention, context insensitivity, and hedonia. But again, these are basically emerging from the way we are rating functioning along these basic brain circuit. So this figure from a 2017 paper highlights how we can conceptualize different patient profiles. So you can rate them along those kind of networks that they have identified. So one person can be kind of high, medium on the rumination default mode circuit, or kind of low on apprehension, but high on the anhedonia kind of circuit, or kind of low on inattention, etc. So every person along these six axes can have different ratings and a distinctive profile on their own. And this approach was partly validated in a 2024 paper in Nature Medicine, in which they used kind of like more complicated machine learning algorithms to identify six biotypes, not six, like more than that, but they identified kind of several biotypes of depression and anxiety. But these biotypes were not subtypes as we typically understand them, not subtypes with each separate causes and essences, but rather these biotypes were in fact patterns of different ways in which these patient profiles cluster together. So, tendencies for these patient profiles to statistically clusters along different lines is kind of like what these were considered as biotypes. So this was kind of like an exemplification of how this kind of approach can be utilized and demonstrated. Now, different biotypes had different associations with clinical symptoms and response to treatment. For example, one biotype was more likely to respond to Effexor, and one biotype was more likely to respond to cognitive therapy. But the magnitude of the association was generally small to medium. So they're not quite ready yet for clinical implementation. We'll see what happens. But at least it's a good proof of concept that we can think about mood and anxiety problems from the perspective of brain circuit profiles, and we can personalize them in interesting ways. I mentioned that complex dynamic systems approaches are making a comeback, and kind of like an excellent review paper of that was published in JAMA Psychiatry in 2024, Dynamical Systems View, and this from a dynamical system perspective. Different phases of mental health problems can be conceived across a landscape, and kind of like the more the it's kind of like the deeper the slope, kind of like deeper the valley in the landscape, the more kind of like the more likely it is that the person will occupy that state and will remain stuck in that state. So you can think of this sort of like, one valley is the healthy phase of health, and one valley, for example, a depressive episode, and the ball can roll between one valley to the next. That is, the person can occupy one state or the other. In a highly resilient person, they basically just have one valley, which is the, kind of like, normal a state of mental health, and the ball is going to stay that way. In a somewhat resilient person, it's going to be really hard for the ball to roll uphill, and for the person to become depressed. Let's say they have a lot of protective factors, low family history, etc. Versus for another person, a person who is vulnerable to depressive episode, even minor things can easily throw this ball over and put them into the depressive valley. So it's a different way of looking at phase transitions between kind of, mental health problems, and thinking of them along a landscape, across attractors. So in a systems framework, pathological abnormal mental states can be understood as maladaptive attractor states that the brain body environment system cannot easily escape. And these states are characterized by insufficient flexibility, resilience, adaptability, etc. And this is from a paper in Lancet Psychiatry, which provides an introduction to this way of thinking. Now, how to handle this landscape of diagnostic pluralism. This was the question me and colleagues were addressing in a 2024 paper in Journal of Nervous and Mental Disease, and Alan Francis was the senior author of that. Alan, as many know, was the chairman task for DSM-4. I was the first author of this one. And we are primarily focused in this paper on the question between categorical versus dimensional approaches to classification, in particular DSM versus high top. And how can we flexibly work in clinical situations and meaningfully make use of high top as well as other other approaches in diagnosis, and think from a pluralistic fashion. So if you're interested in somewhat more detailed discussion of how clinical implementation might look like of this pluralistic landscape, then I would recommend kind of this paper for more details of that. Okay, and now in the final part, I'm just gonna end with some reflections on psychiatry and scientific theory and the current state of that. And there's a general sentiment that psychiatry is operating in a vacuum of scientific theory, which has two sources. There's a theory crisis in psychological sciences going on, and there are kind of like, their neurosciences struggle to theorize the link between brain and behavior. So, according to one way of thinking about kind of like, science, is that our scientific knowledge consists of explanations, what we call scientific theories, and that is a two-step process of hypothesis formation and error correction. David Deutsch, who's a physicist who has been writing about these issues, he says the real source of our theories is conjecture, and the real source of our knowledge is conjecture alternating with criticism. That is, we come up with, through a creative process, we come up with answers to a problem, and then we subject those answers to rigorous testing and critique and see what survives, and then we refine those answers based on, the limitations and problems that we see. So science progresses by good explanations. These are explanations that are hard to vary, that fit existing data, that make testable predictions, that allow for falsification, and allow for the generation of new scientific problems. The problem has to be hard to vary, because if it's too flexible, then you can use it to explain any empirical finding that you will see, and it loses its scientific value if it becomes too flexible. So here's an example of a quote unquote bad explanation in the psychiatry line, which is the dopamine hypothesis of schizophrenia. Kenneth Candler, very well-known geneticist and psychiatric researcher at DSM Insider. He has been a critic, a philosophical critic of the dopamine hypothesis. There was a 2011 paper that he wrote with Kenneth Schaffner on a historical and philosophical analysis of dopamine hypothesis. And later on in a book anthology, Kendall reflects on that. He says, I lost faith in that line of research at the tender age of 33. I was dimly aware that the damn theory was just too flexible. I'm not suggesting that scientists shouldn't try to modify their theories based on research findings. Of course, they should. But when you see a repeated pattern of ad hoc revisions to try to explain the findings that often were not what were predicted, suspicion should arise that the theory might be wrong and other factors outside of science is driving its persistence. As a theory for the etiology of schizophrenia, not for the treatment aspects, but for the etiology, the dopamine hypothesis has performed poorly. It was underspecified and far too flexible. It morphed over time from one form to another in a way that made it nearly impossible to disprove. Now, an important qualification here is Kendler is not saying that there is no relationship between dopamine functioning and schizophrenia. In fact, based on meta-analytic findings from neuroimaging, we know that there is an association that on average, people with schizophrenia have kind of higher presynaptic dopamine functioning compared to not. So it's not a matter of empirical association, but Kendler is saying that whatever that association is, we don't have a good theoretical explanation for it. We don't have a good theory that is kind of precise enough and kind of rigid enough to serve as a good explanation. That is kind of like what Candler is saying. And similar kind of points have been made about psychological theory more generally. So Paul Meehl, very famous, distinguished psychologist, one of the presidents of American Psychological Associations and co-founder of the concept of construct validity, he felt that psychological theory was in a deep-seated state of crisis. And Meehl believed that problems facing psychological theory were rooted in the field's reliance on null hypothesis significance testing as a tool for theory development. That is p-value testing. That it just doesn't give you enough kind of information to kind of to say much meaningfully about a theory. And there are genuine difficulties as well. There are good reasons why we don't have robust theories in psychology. There's a relative lack of robust phenomena that impose constraints on possible theories. There are problems with construct validity. There are obstacles to discovering causal relationships between psychological variables, and there are difficulties in formalizing psychological explanation. That is, it is difficult to express psychological theories in precise mathematical terms. Michael's own suggestion for as a way out of getting out of this was to emphasize risky tests. That is, predictions that would be highly improbable were it not for the theory. He also used the term damn strange coincidence, that a theory has to make some damn strange coincidence that we should be able to then see whether it occurs or not. A good example of this is Einstein's general relativity predicting that sun's gravity would bend light. This is highly improbable. We would not have any basis to think that gravity can, bend light were it not for general relativity. And then in the famous 1921 solar eclipse, it was actually tested and found to match Einstein's prediction. So in the psychological realm, having risky tests kind of means having precise quantifiable predictions about the magnitude of the fact. Not just that it would be statistically significant, but what kind of magnitude we would find. And because such prediction would be unlikely in the absence of a theory, the test puts the theory at grave risk of reputation. And any theory that survives such a risk is strongly corroborated. And of course, we don't really have any theory like that in the realm of psychopathology. In the behavioral neuroscience era, kind of the struggle is how to link kind of brain explanations with behavioral explanations. And the usual neuroscientific kind of study looking at that association takes the form that kind of brain area or brain circuit X is involved in behavior Y. So Luis Pessoa, who is a neuroscientist at University of Maryland, he writes in his 2022 book Entangled Brain, because little is known about how brain mechanisms bring about behaviors, neuroscientists permeate their papers with filler verbs, most of which do not add any substantive content to the statements made. So filler verbs like reflects, reveals, involves, regulates, mediates, underlies, enables, ensures, etc., etc. Something that indicates a relationship, but without offering any detailed theoretical idea of what that relationship is. And neuroscientists are increasingly skeptical that mental categories actually kind of like, have some kind of reality in terms of brain functioning. So Luis Pessoa also kind of writes, mental terms such as perception, cognition, action, emotion, as well as attention, memory, decision making are epistemically sterile. The vertebrate neuroarchitecture does not respect the boundaries of standard mental terms. And Lisa Feldman Barrett, who has done work in the neuroscience of emotions, she says the idea that there's some kind of strong parallelism between mental categories that neuroscientists use to try and understand the brain and the neural implementation of mental events is just wrong. And they're not even talking about psychiatric problems right now. They're just talking about general mental categories. And if they don't have strong correspondence in the brain, then kind of what can we hope for, psychiatric categories? And so it's kind of neuroimaging research and other kind of neuro brain behavior research is re-examining some basic assumptions. So this is another paper from Lisa Feldman Barrett's group published in 2023. And they looked at three basic assumptions: a localization assumption versus whole brain activity, one-to-one mapping between mental category and brain category versus one-to-many and many-to-many mappings, and then context independence versus context dependence, whether an association holds only in a particular context or whether that association holds in a diversity of context. And kind of like, the historical tendency has been to assume localization, one-to-one mapping, and context independence versus, a lot of kind of, brain behavior relationships seem to lean more on this side. They involve multiple parts of the brain. They have one-to-many and many-to-many mappings, and they are highly context dependent. So to kind of wrap up, this whole discussion that we have had over the past 75 minutes, neo-Kraepelinian assumptions, ideas about categorically distinct disease entities underlying our classifications can no longer be taken for granted. In fact, they're increasingly suspect and most likely false. Our current diagnostic categories are largely pragmatic construct. They're practical categories, despite the aspirations originally to capture natural kinds. The underlying reality between these practical categories is quite messy. It's dimensional, it's hierarchical, it's complex dynamic, subject to looping effects, it's socially influenced, and can be examined ideographically as well as nomothetically. And tackling this reality requires conceptual and explanatory pluralism. And I'll end with this quote from the psychiatrist Edward Charles Spitzka from his 1887 textbook on insanity. He writes, "It may be readily surmised that where the best thinkers have failed to produce an unexceptionable classification, the failure must be due to some inherent difficulty of the subject." So it's not just that we are stupid, but rather these problems are really complex and really challenging, and we are kind of slowly making our way towards a better scientific understanding of these things. So with that, kind of we have about 15 minutes left that we can use for questions and answers. This is my email address, the link to my newsletter as well, and we can open up for comments, questions, etc.
Thank you very much, Dr. Aftab, for this phenomenal presentation. And we'll open up for attendees to have comments or questions, starting with Dr. Casey, our chair of the department.
Can you hear me?
Yes, sir.
Yes.
Good. Well, thank you for a wonderful talk. You have given a sort of a more precise vocabulary to concerns that I think many psychiatrists, both inside and outside of academia, have felt, as you've illustrated, probably for their entire careers. And it's daunting to think of the complexities involved. A couple of questions or invitations for comment. As we move, hopefully, toward a more dimensional understanding of psychiatric disorders, inevitably new kinds of syndromes will emerge in which certain combinations of dimensional factors will occur more commonly in a particular situation than others. And I don't think we're close to that point yet, but I anticipate that. That's the first thing. The second is I like to follow the public's reckoning of psychiatric concerns. There was an article in the New York Times about ADHD last week, and I think you've commented on that already publicly. And it illustrates, or it's an invitation for you to illustrate some of your ideas as they might unfold in the public arena.
Yeah, thank you for the comments and these questions, and you're right, very right on both counts. So the first one, that dimensional classifications will generate new kinds of syndromes or new kinds of categories of their own, and this is something pretty much everyone who is involved in dimensional research acknowledges. So I'm, for example, part of the High Top Consortium, and I'm a part of their revisions work group. And kind of everyone agrees that kind of like high top will require clinical categories, because a lot of clinical decisions are binary. Like when to start treatment, when to not, when to screen. Other kinds of clinic, when to admit. So we need clinical categorizations. We need clinical thresholds, but they have to be guided by the right kind of data, and they have to be context specific. So we need the right kind of data about what kind of clinical threshold, let's say, responds to, aligns well with response to treatment, or at what threshold does treatment make sense. And we have to kind of recognize those thresholds as being pragmatic in nature rather than reflecting natural discontinuities. And this is something that we do in general medicine all the time, because we do have dimensional phenomena in general medicine. Blood pressure is dimensional, so we have essential hypertension. There's nothing naturally special about 140 millimeter mercury systolic, but based on our goal that we want to reduce risk of stroke and heart attack and other events, we draw a pragmatic threshold at 140 millimeter mercury. So everyone kind of agrees that that we're going to have clinical kind of pragmatic thresholds on these dimensions, as long as we don't confuse them with representing essences, and that doesn't hinder the scientific kind of progress into etiologies. Because what has happened is that confusing a DSM category as being genuine categories as DEXA hindered scientific research for decades. So that's one thing. And then everyone kind of recognizes that different dimensional profiles would show different kind of patterns, and some of these patterns would correspond to our traditional psychiatric categories as well. And again, as long as we are clear on the nature of what is happening, as long as we are aware of how a syndrome is being generated from a combination of different dimensions, we can still do adequate psychiatric research and scientific work. With regards to the second question, that's been a big source of frustration for myself. So uh, there's a huge disconnect between this post-Kraplanian understanding of psychopathology and what the public understand, and what has been communicated to the public. I would say even most clinicians are not quite aware of these, theoretical and intellectual developments. So even the average clinician has a very poor idea of how to make sense of all this. The public even less so. And the message that has been given to the public, over the last 20 years is a lot of buzzwords, in the late 90s, 2000, oh, these are chemical imbalances, and then later, or these are brain disorders. They are medical disorders just like diabetes. All of that language invites essentialism. It invites the public to think of these categories as having a distinct essence, as having distinct neurobiological dysfunctions. And so the language that we use for public education reinforce this idea. So when in the last kind of 10 to 15 years we see the kind of this coverage of new scientific developments, we recognize that, oh, these categories actually are not that special. They're fuzzy. They're on a spectrum. There is no biomarker distinctive associated with that. It's very heterogeneous. People who who believed in that kind of crude view of medical model, they respond with skepticism. They're like, oh, we were lied to. This is all bullshit. This is all socially constructed, etc., etc. Because they swing from one extreme to a kind of another extreme. And I think this is primarily a failure of scientific communication on part of the discipline, that our public communication is so impoverished that we didn't give public the tools to understand these problems in a sophisticated manner. So it's going to require a lot of effort. It's going to require us to talk about these things in a dimensional manner, in a spectrum manner, talk about the biological heterogeneity, talk about how they are not just biological dysfunctions, but rather, arise from a combination of different factors in a complex fashion, things like that. So it's going to take some work on our part, and the ADHD article was just a good illustration of the public reaction.
Thanks.
Any other questions for Dr. Aftab? Thank you very much. That was very insightful.
Okay.
Please raise your hands on Zoom or type it in the Q&A. I do have similar comments to what Dr. Casey made about, you put in a lot of structure to something a lot of psychiatrists, even psychiatrists in training like myself and other residents and students think about psychiatric diagnosis and classification. We are asked to do a grand round presentation at the end of our residency, and mine was a case formulation for psychiatry as a discipline itself. We talked a lot about the mudding of psychiatric disorders and the classification and diagnosis in that talk as well, and the dimensional approach. But I want to get your opinion about one of the prominent thinkers in our field, Dr. Gami, and his approach to a little bit hanging on to some Kerplanian ideas. And in the tradition of William Osler's, his model is called the biohumanistic model. So how do you think this can relate or work in tandem with the high top model, or is it too distinctive that they kind of go against each other? I would love to hear your thoughts.
Yeah. So I mean, I know Dr. Raimi very well, and we have collaborated in the past on kind of different things as well. So I'm familiar with his ideas, and he does. So Dr. Raimi still holds on to the view that um that underlying kind of schizophrenia and underlying bipolar disorder, properly understood through in a Kerplanian fashion, that there are biological dysfunctions, that we will be able to identify properly. He's kind of the view that just as Kolbam and Hecker felt that, if you get the phenotype right, then you can, do the etiology right. He still thinks that, the DSM-ICD phenotypes are not the right one. And if we took the right phenotype approach, then we will be able to better kind of make progress. I think at the moment, Dr. Raimi is increasingly isolated in taking that view. Most other people who have examined the data and looked at it have shifted away. So Kenneth Kendler, for example, he kind of, moved away from that thinking and realized that we're probably not going to see neurosyphilis-like findings. All of the psychologists who have been working on the dimensional models, they're just, the data just doesn't support it. We just don't see evidence of that. Now, could it change? It's not looking very likely, but if new kind of findings come up, we'll see. So I would say it remains increasingly speculative and less supportive. Um, it's not it's we cannot say that it's been conclusively disproved, but I personally find it less and less likely.
Thank you so much
Yeah.
for your answer. We do have a Q&A in the chat from an anonymous attendee about how much diagnostic uncertainty is driven by use of diagnoses to meet indications in order to attain insurance authorizations.
Oh
And
yeah, it's a huge. Yeah, and I mean that's a problem in kind of in practical settings, is that we are driven by these practical considerations, and oftentimes we kind of use billing to serve those practical aims of insurance coverage rather than fidelity to the clinical assertion. And I think this is um so I think we have to keep that in mind. So I think, there's definitely on the practical side, we're going to end up using that perhaps don't represent the actual thing, but we have to still be mindful of how we communicate that to patients. I think we need to make some effort at clarifying that if we are using a diagnosis just for pragmatic purpose of satisfying insurance, that we communicate to the patient that that this is what we're thinking, and that what might a more accurate clinical or scientific diagnosis look like if we were doing that. And then I think, hopefully, the profession can also lobby or, move in a direction where we are not in this situation where insurance coverage does not depend on such strict categorical, misuses of diagnosis. So I think there's some practical work that needs to be done. But I understand, I'm a clinician myself. I face the same pressures. But I think it's okay. But I think, it puts a certain responsibility on us that then we have to accurately represent that to patients too, so they don't misunderstand their own condition.
Absolutely. Thank you for your answer. Definitely hope to see some kind of application of that in the future and maybe in our communication with our patients or just like in our documentation, maybe as it gets easier in the future to have like a
Yeah,
high top graph next to the
yeah,
MSE
yeah,
or something that would be fantastic to see in the future.
yeah.
Our last question of the day is from Dr. Suleiman, our attending at the VA. She wrote, any thoughts about how social media creates more confusion in public about psychiatric diagnoses these days?
Yeah, I mean it's a very kind of fascinating and kind of interesting topic, and not super related to what I'm saying, but I think I think the social media part, I think it's particularly highlights the looping effects and the dynamic effects that giving humans diagnosis is not like giving a species a taxonic classification, but rather humans relate to these labels. They have feelings about them. They can find the labels validating. They can find them dismissive. They sometimes they want to expand these labels. So I think a lot of what is happening in social media is this messy relationships that humans have with psychological labels and psychiatric labels, and then in social media, they take on a life of their own, and through iterative process, they become increasingly disconnected from the clinical understanding. So, an average, TikToker's idea of autism and ADHD is very different from the DSM conceptualization of ADHD. So it presents challenges, I think, for us where we have the same terms and the same categories, but there's a strong misalignment between them. That the social colloquial use of these terms has acquired different significance from the clinical use of these terms, and that is something we have to kind of somehow manage in clinical settings. That we have to recognize that patients have their own idea of what this means, and we have to help them translate kind of how it means. I'm somewhat conflicted because I think cultural evolution has its own force, and we can't always control the kind of terminology and vocabulary that people will use to try to understand themselves. And so, unlike others, I don't think we can successfully police it. I don't think we can police what is happening on social media because it is so organic and messy. But I think the best we can do is that at least not let the two conflate. At least we can let kind of be clear and distinct in our heads that there's this social conception of what ADHD autism is, and then there's a more clinical understanding of it. And we can help patients navigate and translate between these two conceptions better.
All right. All right. Thank you so much again for a very insightful answer. And thank you for being here today and being generous with your time and your knowledge. And thank you, everybody, for your attention today during Grand Rounds. This will be recorded and uploaded to our YouTube channel if you want to review some of the fantastic points made by today's speaker. And have a good rest of your day. Thank you.
Thank you. Bye.